All right, everyone, we are live now. Dr. Volberding?
Great. We have what I think is a treat today. First of all, welcome, and even before we start, just reflect for not a full 9 minutes, but reflect on the events of the last couple of weeks in Minneapolis and elsewhere, and we'll all, I think, commit ourselves to doing better in the future. So the program today is a unique one for IAS-USA because we've done a lot of educational programs over the years. But what we're going to do today is we think educational, but in a different way, and really in a conversational format. We have a spectacular person joining us, a true expert in this area. I would say that George Rutherford, who's our panel today, is really a seriously deep expert in pediatric infection and infectious disease epidemiology. We will not be talking about clinical management of COVID-19. But we will be talking a lot, I hope, about the natural history, the controversy surrounding testing, and how we and the world have responded to the pandemic. So George is a professor of epidemiology and biostatistics at the University of California, San Francisco, where I'm also employed part-time. And what we would like to do is jump in. What we'll do is talk for about 40 minutes about some of the questions that I've been thinking about. We've all learned so much in the past few months. And then at the end, what we'd like to do is try to save about 20 minutes for questions and answers from the audience. We have a system of where you can ask your question. We have staff that will be kind of helping give those to me, and I'll pass the ones on to George. I'm sure we won't be able to get to any large fraction of the questions that people will have, but stay tuned, and I think we'll hope to do some other of these conversations again. So George, welcome to the webinar.
Thanks, Paul.
And you can now see, the audience can see us. I think they can also see the window at IAS-USA in San Francisco with the big notice at the top of thank you, Dr. Fauci. And I think I'm not going to ask George, I don't think about Tony, but it's been interesting watching how important he's been in the response to this epidemic. George, okay, so you have been on the road. You, I think maybe it's you and Ashish Jha and some others who have become overnight experts in this group of viruses. And I think I'd like to start by having you spend a few minutes, and I think it deserves it, to talk about the various testing platforms. We know that there are antigen tests. We think of those as being somehow related to infectiousness or symptomatic states. We've also heard a lot about antibody tests, and we think about those typically as a marker of infection or a marker of immunity. Can you kind of help set the record straight on those two broad variety of tests and what a clinical audience should really understand?
Yeah, so thanks, and thanks very much for having me, Paul and Don.
Sure.
It's a pleasure to be here. So pay attention to PCR testing most. PCR testing is, if the virus is present, it will detect it. There are some window period problems with PCR testing and the likelihood of not having a positive test when in fact you're infected but not yet shedding virus. And typically that window period's 3 days. but it may be as long as 7 or 8 days. There was a very recent paper in Annals that talked about the negative predictive value of the test, and it had minimized at around 7 to 8 days.
So let me just interrupt, George. So you're saying from at the time of exposure until infection is several days, or
From the time of exposure to the time that you're able to detect virus
right?
by PCR is usually 3 days. That's a kind of round number.
Right.
A median of 5 days incubation period from infection to onset of symptoms, and you typically start to shed a couple of days earlier. Now, those are all medians, so if you want to really have kind of the highest yield, you're probably talking 7, or the least chance of having a false negative, you're probably talking 7, 8 days. But I say 3 days is the answer that I always give to that question, understanding there is some variation in it. So PCR is great, and one of the things we're learning about PCR that I hope we're going to start employing more of is to pay attention to the cycle times and the thresholds. Right now we cycle it, 40 times before we call it negative. And a lot of these things you hear about people who test positive, then negative, then positive, then negative, they're right around 39 as their cycle time. So rather than thinking of them as intermittent shedders, think of them as kind of flirting at the edge of non-detectable. And some days that they're detectable and some days they're not.
So just to kind of orient all of us. So the more, it's not that the
like golf.
More cycles are more virus, it's more cycles is less virus. So the
Correct.
fewer cycles it takes to find it,
right,
that implies that you have more virus.
Right. It's like, it's like golf, right? So low is good if you're the virus, and high is bad if you're the virus. For the humans, it's the other way, or it's the other way around. So one of the things we're starting to pay attention to and trying to latch onto a little bit more are cycle times for things like contact tracing. See if we can predict people who are the most infectious, who have the most virus. So if you have like a cycle time of 5 or 6 or 7 or 8, you might have 10 to the 10th particles in your anterior nares or in your
again, I'll interrupt to ask whether we know enough about the so-called super spreaders. Are those people with high viral loads? Is it like HIV? Is it the more virus, the more likely you are to spread it?
I don't know that we know that as a fact, but I think it's certainly smart money would say that. And so, one of the things, so if you think of syphilis, you think of people who have, who are dark field positive for syphilis, who are being really infectious. That's the same kind of thing, that these are people who are really, and we think they're really infectious, so that they become the priorities for contact tracing.
Got it.
For interviewing and contact tracing. So that's nasopharyngeal swabs. There is an EUA now for nasal swabs, anterior nasal swabs only, but just for people who are symptomatic. And for those of you who remembered having a nasopharyngeal swab, if you haven't had one lately, they're not the world's most comfortable thing to have, but it's, it's not the end of the world. As a pediatrician, I used to do lots of them.
Right.
And yeah, it always made them cry, just to fill in the blank there. Because you do it for pertussis. It's how you get the material for pertussis diagnosis. Anyway, be that as it may. So that's the gold standard for diagnosis. Although the Chinese are very fond of lung CT scans as another gold standard for diagnosis. The antibody testing is okay. The market flooded with something like 90 different antibody test platforms in a week when FDA was accelerating things by basically stamping everything that went by. And it's taken quite a while for that to sort out. Antibodies don't become positive. They don't become measurable until 11, 12, 13 days post-infection. So it takes a while to get an antibody test positive. And so they're, I think, of limited clinical utility acutely to make an acute diagnosis. Although you can imagine somebody going to an OR and they might be beyond the time when they might be nasal NP swab positive, and you can find the antibodies and they might have been recently infected. Anyway, there might be some clinical use for it. But the larger use is for me in terms of seroepidemiology and being able to understand how many people have been infected and what the patterns and distributions of disease are. They're also helpful if you know someone has been infected and they have antibodies to start trying to sort out who has a high titer neutralizing antibody for purposes of plasmapheresing off antibody for convalescent plasma therapy.
George, what do we know about those people that have neutralizing antibodies in terms of their risk for reinfection? We've heard various things during this whole pandemic.
Yeah, it's up in the air. We don't know. I personally know of no cases of reinfection. You know, there are these people who have sort of intermittently shed. Korea, they were on the Theodore Roosevelt in Guam. But I think that's much more likely to be explainable by the fact that they have low titers and you're just kind of amplifying small fragments of RNA and it's not correlated necessarily with viable virus.
And George, with HIV, we know that there's a lot of talk about replication competent virus versus non-replication competent. I'm not sure exactly what that means, but I guess it's a kind of a damaged virus in some sense. Do we see the same thing with this virus?
Yeah, absolutely. I mean, it's not necessarily damaged, just pieces of it left behind. I explained it to one of my kids who was asking me. It's like, you know, you go out on you go over to some after work party and you come back with a long blonde hair on your blue blazer. What exactly does that mean? It means that somebody who owned that long blonde hair was around once. So it wasn't me. Yeah, it wasn't you. I know that. Yeah, I actually knew Paul when he had brown hair. So just, as he knew me. It's just a piece. You know, it's just a piece that's hanging around. That we have such sensitive technology that we can amplify it. Up.
Right.
There's one good study that was done in Germany, where they looked at both PCRs and tried to culture virus at the same time. And they were unable to culture virus 8 days after symptom onset. And that's the one best study we have that looks at. It's also a small study, but it's not. You know, this stuff gets dealt with at biosafety level 3. So it's not like everybody's setting up labs willy-nilly to grow it and stuff. But that's the one thing we know. So antibodies, you know, those are the uses of antibody. Now, the next question is, does having antibodies equal immunity?
Right.
So what I can tell you is that some portion of people who have clinical disease and positive PCRs and recover have no measurable antibody. That's as much as maybe 10 to 20% of people. This is after the hospital course. There are also a small number of people, probably less than 5%, who have very high titers of neutralizing antibody. Those are the ones they're looking for plasmapheresis, and then everybody else is in between. Is that
unusual, George? Are there other infections that don't lead to an antibody response?
There are infections. A lot of respiratory epithelial infections don't lead to particularly robust antibody responses, like the alpha coronaviruses, for instance. You know, just because they don't necessarily get into the bloodstream and pump up, IgG. So I mean, we're not looking for IgA. I mean, we do look for all antibody, but unless you're fractionating out IgA, it's going to be hard to really tell. Yeah. I think the other thing to say is, you know, we don't know how protective that antibody is that people have, and we don't know how durable it is. And so those are big questions that are being asked.
With a lot of implications for vaccine development, obviously.
Massive implications for vaccine development. Now, the other thing is, though, I mean, don't forget this is still circulating a lot, and in fact, more than it ever has, all over the country. And so people are coming into people who have antibody are coming into contact with it again and again and again, and they may be getting naturally boosted as well. You know, which is why, like in the 19th century and early 20th century, smallpox vaccine worked so well because people are getting naturally boosted all the time. Right. Now, when we give it to the military, it's always sort of a crapshoot if it's really going to work or not. So I think you're going to see there probably is some natural boosting. We're putting a study together that's going to go into the field next week with healthcare workers, and we'll follow people who develop infection for it to look at their evolution of their antibody responses, but also follow them over time to see if they get reinfected. I mean, that's the most likely population to get reinfected.
George, another direction I'd like you to take us is this controversy. It's been around a while, but it's been hot again in the last couple of days after the WHO comments. Yeah. What do we know about asymptomatic transmission? How likely, if you're on a bus and people aren't symptomatic, what's your risk? Is it less? What is the likelihood of a person that's asymptomatic transmitting this virus? To talk about that and talk about the controversy in the last couple of days.
Sure. I think that so to start with, there's some conflation between people who are truly asymptomatic throughout the entire course of the infection versus people who are pre-symptomatic,
right,
who you're catching in this early period before they develop symptoms of a couple of days. And what what WHO was talking about, it's actually one person at WHO, was talking about were people who are asymptomatic throughout the entire duration of their illness. And I think in kind of public health practice, we think of asymptomatic as people don't have any symptoms at that moment in time, which is a lot more common. There are two big reviews that have come out that estimate the prevalence of true asymptomatic infection at somewhere between, one estimates it at 15% and the other estimates it at 40 to 45%. These are systematic reviews that take studies that actually have follow-up, so you really know if they develop symptoms or not. And you know, I think that gives you kind of a rough feel. I usually say around 40% are truly asymptomatic. What I really should be saying is that on any given day, 40% of people are truly asymptomatic, and maybe another 20 are mildly symptomatic. So mildly symptomatic, they don't show up for work. Are people who are asymptomatic less likely to transmit on a per person basis, on a per exposure basis? Yeah, probably. They probably have lower titers of virus, so that means they have higher cycle times on PCR. The literature on that's very mixed right now, but I'm guessing. Are they important for transmission? They're hugely important for transmission because there are so many more of them out walking around. You know, people who are sick are staying home, so they're not exposing other people. And in Wuhan, before they really understood what was going on, the estimates are that 79% of transmission was due to people who were asymptomatic at the time they transmitted. But remember, asymptomatic people can become symptomatic as well as stay asymptomatic the entire time. And they'll shed throughout their illness, at least until, whatever the 8 days or however it works out.
So, George, I'm sure you remember we were both at a meeting at the university, and the announcement was made to start working from home. And the proposal was start working from home at the end of that week. And I remember you exploding and saying, why the hell would we wait?
Yeah, exactly.
We should do it now.
Well, because somebody was doing a study, I think, but
But I think that really woke me and others up to kind of the seriousness of this. And so you obviously have thought a lot about sheltering in place. But talk about what we've learned, what has worked, what's the evidence that it's worked, and compare that with what we might be moving towards, which feels like less sheltering and more mask use.
Yeah.
But just talk about that some.
So I don't know if you have read this guy whose last name is Puello or something. I can't. I want to say Puello, but that's somebody I went to medical school with. And he talks about the hammer and the dance. And Paul, you're an oncologist, obviously, and this is about kind of debulking, and then kind of the big whack, and then maintenance therapy. The big whack is shelter in place, for which, there's some evidence that it's, there's a lot of evidence that it's worked. it's a little unclear how much, how much is really going to stand up to the scrutiny of, say, the Cochrane collaboration or, people like that. But it's, sorry, I just had to extend my computer, giving you an idea of when I get up in the morning to start.
Right.
Sorry. But I think it's my favorite graph are these two almost contiguous states, provinces in Italy. One's Bergamo and the other is a town called Lodi. And they're not totally contiguous. They're about 60 miles apart, I think, as I look at the map. But Lodi was the place where the first super spreader showed up in the ED in Italy. And they infected 35 people on the first night. And the government went to shelter in place very early. In Bergamo, they went to shelter in place about 2 weeks later. And the difference in the curves is just astounding. The Lodi curve is kind of flattened, and the Bergamo curve is, kind of up off the edge of the graph. So being nothing but competitive, even though I did grow up a Dodgers fan, I have to say, I put the San Francisco and Los Angeles on the same, did the same thing. Los Angeles went to shelter in place 4 days after San Francisco, but their first day of shelter in place was a Friday, and it was like people really didn't get the memo until Monday.
Right.
And so it was kind of business as usual on Friday, Saturday, and Sunday. So it's almost 7 days later, 6-7 days later. And it looked just like Bergamo and Lodi. And there was a big difference. And if you could do a Bay Area wide versus Southern California, same thing. Now we're starting to get models, people who are modeling this, and estimating the numbers of cases that have been averted. There was some people from the public policy school at Berkeley that just published in, I think, Nature Medicine. I can't remember exactly where. And they were estimating the numbers of, the tens of thousands of cases averted in 6 countries. So we're getting some better modeling of that from shelter in place. But I think you have to kind of walk away and say it made a huge difference. It made a giant difference in Wuhan, where this was just going to go out of control. So I think we're pretty clear on that. Now, the other thing is, and this was, and different states did different things. There'll be a million doctoral dissertations that will follow from this over the next 50 years that will compare this state to that state or this region to that region based on when they went to shelter in place relative to the background, to when the infection started to spread. This isn't rocket science. I was sitting in an early March. I was sitting in a meeting in the director of public health, with the director of public health in San Francisco, and both my counterpart, Art Reingold at Berkeley, and I both brought up St. Louis in 1918. And the lessons of St. Louis, which did really well, was that you need to go to these very restrictive measures very early on. If you wait to start accumulating deaths, it's going to be way too late. And the second thing is that if you stop them too early, you'll get a rebound. And I'm afraid that's what we're going to see around the country, that we've stopped them too early. Now, do masks work? Masks are huge. But just remember that masks are about source control. So I wear a mask in case I have asymptomatic infection or pre-symptomatic infection or mild infection. And it's to protect the people around me.
I've heard that, George, and I believe it, but I've also heard that masks might actually play a role in protecting one if you're exposed to the virus.
Yeah, and say, just in terms of, if you want round numbers, these are very round numbers. A mask will cut down the probability of transmitting out from you by 90%. If you have a mask on, it'll cut down your probability of acquiring infection by maybe 30%. And that's because your eyes aren't covered, right? Unless you're like us and have to wear glasses all the time. It's, because the respiratory, kind of the conjunctiva are part of the respiratory epithelium. So I think they give you some break. And I have a daughter who's a counselor in for sort of special ed kids in Alameda County. and they have to go to these meetings in these sort of small rooms, and God knows where these kids have been, right?
Right.
And she says, well, what am I supposed to do? And I said, well, you can wear both a regular face mask and then wear an N95 over it, right? It's not, you want the N95 protects you from getting infected. The face mask protects them from getting infected. There are some being designed that they have both, you get sort of two-way protection, but those are kind of still off on the drawing board. Well, they may be around by now, I'm sorry, but
I've been wondering about masks with a hole in the middle for a straw so you could go into a bar without taking off your mask. But
so the Navy has those, okay?
is that right?
And they have these really cool ones because people have to wear them 24 hours a day. They have to sleep with them on in these ships when these big outbreaks. And they have straws that come up. They come up through here, straw holes. And they also have microphone jacks so that if you're an officer, you can yell at everybody.
Good.
There's some things to be said.
George, something that we've also heard about in the last week or so, I think, are estimates on I want to talk about natural history in a minute too, but we've heard that young children, we know they can get infected. We know they can get these unusual inflammatory conditions, but we've heard that they're less likely to be infected and less likely to transmit. And it seems to me that given the problems that we're facing with no daycare and no preschool, no early elementary school, that if we knew that kids couldn't or wouldn't likely transmit, that might allow us to change our policies. You want to talk about young kids? You're a pediatrician.
With 6 kids too. So,
yeah, and your wife's a pediatrician. So.
Which is why we have 6 kids. It's one of those risk groups, The evidence base for this is about that big. Okay, so take everything I say with a grain of salt. The evidence from China was that very few clusters had a child as the index case. They were almost always at sort of the end of transmission, where somebody brought it into a family group and then it got transmitted around and eventually got to the little kids. There have also been school outbreaks that have been worked up, and those have all been in high schools. There's a large ongoing outbreak now in Israel in high school, among high school students. And so out of the blue, a group from, I think, Mount Sinai in New York, it was an asthma group, had all these biopsies of nasal epithelium across the lifespan, from fetal tissue all the way through to older people. And what they could measure, then they measured the prevalence, the expression of ACE2 inhibitors across all that spectrum, and they found that it was that the expression of ACE2 inhibitors was very low in fetal life, in infancy, in childhood, really up to about the time of puberty, and then it started to go up, and by the time you got to about 17, it was the same as it was among adults. So that gives you a physiologic basis for why why littler kids may not be as ready transmitters. Now, having said all that, I think you'd be crazy to bet on it at this point in time. I think you have to basically have some.
Because parents are really going crazy
it.
dealing with this issue of the kids at home and not in school.
Well, I think they should go. I think you can go back to school. It may not be quite what you have in mind, but it's going to be something like that. There are huge socialization things, and little kids don't learn very well from the internet. And it's, I think for elementary schools, you could see like a morning, afternoon, or a Monday, Wednesday, Friday versus Tuesday, Thursday, Saturday, somehow trying to get the instruction in a way where you have half the classroom filled, and to the extent that they can wear them, wearing masks. I have a great picture of my granddaughter with me, 2-year-old, trying to, their hand trying to pull her mask off and my mask off at the same time. It's going to be tough for little kids. And if it's under 2, there's a suffocation risk. So you want to stay away from that. Now, having said all that for elementary schools and probably for early middle school, once you get into high school, it's completely different kettle of fish. And it's going to be, you're going to have to really be creative. And the whole idea is that you'd like small groups of students who are cohorted together. So if the infection gets into one group, it's not going to spread widely. So what does that mean? It means that you take, some number of kids who have roughly the same schedule, you plop them down in a room and the teachers rotate in and out, okay? Then if they're taking, second year Chinese, that might have to be online or something else, maybe either asynchronous or synchronous. So it's gonna be complicated and not necessarily very easy. Extracurricular activities are going to be tough. I mean, clearly there are a few that you could pull off, like golf or maybe even tennis, but choir, no way, right? It's all those sorts of things are going to be hard to do, unfortunately.
So another topic that I know we're thinking about. So we're sitting here. We're still in many cases, hopefully sheltering in place, staying at home. But people, as we've heard, are getting antsy and are just breaking out anyway. And I think the challenge then is, are we just going to see this continue? What about the summer lull, if I can put quotes in the air? We think of flu as having a summer lull and then a fall spike. Do we know enough about this virus to predict whether those things are going to happen?
No, we don't know enough to know that whether those can happen. What I can tell you, so we just had a paper accepted to JID that refused the Southern Hemisphere's experience with SARS-CoV-2 before it became fall there. And, there are thousands of cases and, there's not a lot of, all this stuff about temperature and this is going to go away because the temperature goes up. You might get maybe a 1 or 2% decrease. It's not going to be much. The reason flu goes away in the summertime is because kids leave school, right? So they're no longer in school. They're no longer amplifying it, which is another reason why trying to figure out what's going on with elementary school children is so important. They're huge amplifiers of influenza A. I've been told,
from what you said, we would guess that they're probably not huge amplifiers of this virus.
Guess is the operant term here.
Right.
But I would think that, it's a bet I might take.
So another thing that we've seen, obviously now, are these mass gatherings, whether it was Memorial Day in the pool at Lake of the Ozark or in the last couple of weeks, the huge protests where people are jammed together, usually without masks. Have we seen anything from that yet? And what would you, I can guess what you're going to guess, but give us some thoughts.
I think we've seen the consequences of Memorial Day. There are big upticks in states like Arizona and Texas that are very rapid and really look like point source exposures, which are from the Memorial Day weekend. And I got this, not to pick on Arizona, but I have this picture of a Memorial Day weekend in Scottsdale, and it's a 2-story bar that's jammed to the rafters, just jammed, and not a single mask in sight, as you might imagine. And that's there are going to be consequences of those things. Now the marches are a little different because first of all, they're outdoors, okay, which makes somewhat of a difference. And the second thing is, at least here, there are a lot of people wearing masks. Now in Southern California, I realize it might be a little different, and in other places it's different. But we haven't seen the bumps up yet. And that includes both in DC and Minnesota the last time I looked, which was yesterday. So you would expect to see cases. And remember, when we talk about cases, we're talking about diagnosed cases. So people have to be sick enough to present for care, right? Typically. Even though there is now CDC's recommended that people go get screened if they've been to the protests. But we're not seeing the cases yet. And we may see them go up soon. Smart money would say that they're going to go up eventually, but we just haven't seen it yet. Now, how much are they going to go up? Masks give you a ton of protection if people have masks on, if the bulk of people have masks on. But that includes the law enforcement people too. I mean, they're equally susceptible and equally likely to be infected. It's the right age. It's the people who are with asymptomatic, pre-symptomatic infection tend to be younger and not over 50. So everybody's got to have their masks on, right? Obviating against that is that there's no social distancing. People are chanting or yelling or whatever. What we know is that singing is a dangerous activity, and there can be big spread events from singing. And so I think you'd have to extrapolate and say that's the case. And then finally, tear gas is a respiratory irritant. And we think of it as just irritating the eyes, but it irritates the entire respiratory tree and causes people to cough. So coughing is bad. Coughing is gonna X out a lot of the protective effect of masks. So it's a balancing act for now. Paul did we just lose you, Paul? That cat must have stepped on something. So let me just keep talking. One of the other questions that I keep getting asked is is there going to be a second wave? And as I alluded to earlier, a second wave may be with influenza. So with the 1918 influenza, for example, there was an early spring wave, which was largely concentrated among the U.S. military. And when the troops went to France, to England and France, they took the infection with them. It spread over Europe. It crossed into the German lines and spread through Central Europe as well. What we know from that was that, but after there was a sort of general subsidence, and then starting in September, there was a second wave of infection, which was much worse than the first, with lots more cases. And then eventually in the spring, there was a third wave of infection from the H1N1 virus. So what do we know about transmission in that setting? What we know is that cities that went to social distancing earlier were much more likely to have blunted second waves. And that includes St. Louis is the textbook example, but also San Francisco, which probably had about a third of the predicted number of cases. As a port city, San Francisco was supposed to have a lot more cases, and it did, but we meaning San Francisco, gradually went to more and more restrictive measures and eventually ended up with a mask ordinance in mid-October. Following that, there was a lot of kind of push-pull. There was, every talking head in the world would say masks are good, masks are bad. It's not salubrious. And, this is when people believe that fresh air cured tuberculosis. So there's a lot of kind of climatotherapy stuff mixed up in this. But what we know is that eventually on November 21st, the anti-mask ordinance was rescinded in San Francisco at noon on November 21st. This is 10 days after Armistice Day. All the sirens blew and the whistles blew in the city, and people pulled their masks off and threw them away. And the paper talks about how there was a sea of gauze masks all up and down Market Street. And within 2 weeks, there had been 600 new cases of influenza, and by the end of February, there are probably 1,400 additional deaths, which would not have happened had they not rescinded the mask order prematurely. So there are consequences to ending these policies early, and we'll just see. We'll just have to see how it goes. I suspect we're not really going to see a true second wave. We're just going to see the continuation of the first wave as we go forward through the summer. And for those of you who spend as much time in the Pacific Ocean as I have, that waves run up the back of each other. And so you get a waveform that looks like a wave, but then it's sort of a little dip, and then there's another bigger wave behind it. And I think that's probably what we're going to be seeing, except maybe in places like New York and New Jersey and Connecticut, which have had true up and down waves. Paul, you back?
George, we've lost Paul. We're trying to get him back. But I wonder-
Hi, George, can you hear me?
Yeah.
Great, I'm sorry. I think I lost my Zoom connection here at my house. But I really appreciate what you've been talking to us about. What I wanted to just have you spend a minute or two talking about some of the controversies surrounding the agencies that we've come to rely on, the CDC and the WHO, and they seem to be not making great leadership strides. Can you talk about that a little bit?
Yeah.
And then after that, George, if I might interrupt, sorry, Paul cannot see the questions that have come in from the participants. So after you address that with that comment, maybe you can go onto the Q&A button and take a look at some of the questions that are coming in.
Sure. So these are challenging times for CDC and WHO. WHO is I think is a real excellent organization. It's had its funding cut so much over the years that we warn our medical students when we send there for rotations that they're going to be making copies. I mean, that's basically what their role becomes. It's so badly underfunded, and it's been very demoralized over the years. It probably has a third the number of people that it needs to have to do what it's charged with doing. Added to that, there have been there's a lot of internecine warfare among the UN agencies. At least there was with HIV, and they finally had to form a whole new HIV program called the United Nations Special Program on AIDS and HIV, or UNAIDS. And then there's the Global Fund on top of that. So it's, there's like some element of not being able to play nicely in the sandbox together. But the U.S. has been kind of leading the death by 1,000 cuts at WHO. And in fact, a big chunk of their money comes from the Gates Foundation, which I think has been viewed as, it's obviously, it's great to have the money, but it gives the Gates Foundation a lot of influence at WHO, which is meant to be an organization of member states rather than private philanthropies. On top of that, Dr. Tedros is a relatively new director general. He's only been around since last May. So there's a lot of there's a lot of turmoil there, and it's not as effective as it could be, but that's kind of the structural thing that we've created, frankly. CDC has been similarly demoralized over the years, starting in the Reagan administration, with non-career people largely coming in as directors of CDC, who may have some background, but haven't really come up through the CDC system or even the U.S. Public Health Service system. I'll remind you that Dr. Redfield is the second director of CDC under President Trump. The first one was a woman from Georgia whose name I can't even remember, who'd been maybe the state health commissioner in Georgia, but turned out had a ton of money in tobacco stocks, or at least I think it was probably in blind trust, but she didn't know not to say that, and she ended up having to get squeezed out. So it's, I think it's, and they didn't do very well on this, quite frankly. And I think that they have good connections with the Chinese CDC and helped build the Chinese CDC. By the time the Chinese CDC figured out what was going on, presumably, Dr. Redfield tried to engage, but got shut out by the White House and wasn't forceful enough or whatever, didn't have enough allies to push the agenda. And then screwed up the lab part. And it's just been catch up since then. So I'm, it's going to take a long time to rebuild CDC. Lots of people have left.
Right.
Your city health department, however, in San Francisco is strong.
Yeah. No, we've always been strong. So I'm sorry I was interrupted in my Zoom connection here.
Is that cat?
Yeah, more than one.
Chewing on the wires.
I think I'm back. So Donna is going to be, and the staff are going to be giving me some questions, George, to pass on. I'll try to do as many as we can. Maybe let's try to be
Paul,
brief.
go to the Q&A button
I've got it.
down at the bottom. Open that up.
I've got it.
Great. You should be able to see the questions in there.
Right. So from CHRP, that we're talking about the sacrificing the few for the benefits of the many. Comment on that. Therefore, Lisa's asking whether we've sacrificed the many for the benefit of the few. You want to talk about that?
Well, I mean, it's a numbers game, isn't it?
Yeah.
And, you know, you could say that there are, you know, 2.2 million Americans we don't really need, who've paid their taxes and fought in the wars and, you know, built the economy and did everything else. And now, you know, the first day it gets tough, everybody dumps them. That was what the mortality estimates were in the first Imperial College models. And I think we've done a remarkable job of.
Are we moving back to that almost as a strategy? Are we?
No, I don't think so. I think what we're moving back to is more of a model of individual accountability, and like by wearing masks and maintaining social distancing. And I think that's it wouldn't have worked in the first place. Let me put it that way.
Yeah.
It's hard to, you know, it's not South Korea, it's not Taiwan, it's not Singapore. And we, you know, I mean, I think you might have been able to do more piecemeal shutdowns and not wreck the economy of Montana. But, you know, in most of these places, you're going to have to have this sort of big hammer blow of interventions. As I said, you know, like debulking the tumor, and now trying to maintain the effective reproductive number as close to 1 as possible until we get vaccines. And vaccines are huge, and that's an important thing to bring up. We'll probably have some by early 2021.
So one of the questions I have is one that I think we've all thought of as well. We had SARS back in the day. It was around for a while. It was scary for a while, and then it went away. Is this going to disappear like SARS? Do we know? I know we don't know yet, but what's your thought?
It's hard to imagine with 7.5 million cases worldwide that it's going to completely disappear. SARS went away. SARS was largely a nosocomial disease. Yeah, yes, there were some weird things that happened, and yes, there was community transmission, but it was still largely a nosocomial disease. And so if you can control nosocomial transmission, you can control SARS. And in fact, there was an outbreak the following year of SARS, but it was in a virology lab in Singapore.
Got it.
So
also nosocomial. So, so this is a tough question. This is politics again, but that's where we are. Question about vaccines and kind of how politically weaponizing the development is. Got to get something out before the elections.
Well, it ain't going to be there before the election, so don't worry about that too much. 5 of the 10 vaccines in trial are Chinese.
Right.
But I guess that's off the table. The U.S. has decided to back 5 vaccines in Operation Warp Speed, this new vaccine push. Pfizer said no thank you, so it's down to 4. 1 is an mRNA vaccine. 2 are adenovirus vaccines that are expressing the spike protein or the binding domain of the spike protein. And 1, which only uses is using recombinant vesicular stomatitis virus to express the binding domain. That's the only platform that has been successfully used for another human vaccine, and that's for Ebola vaccine. Now, betting, you know, who knows what's going to happen, but both the Moderna mRNA vaccine and the Oxford/AstraZeneca adenovirus vaccine are in phase 3 trials. The Oxford one is AstraZeneca has just started, and the Moderna one will start in July. So we should have answers pretty quickly, given the rates that transmissions look like they're going right now.
Although we won't know for a while whether there's any possibility of ADE or the enhancement of infection that might be the side effect of a vaccine.
Right. So ADE is antibody dependent enhancement is an issue, and that like you get in dengue, where you have one serogroup of dengue and then you get infected with a second serogroup of dengue and you get a much worse infection. There's some suggestion that that might be what the Kawasaki-like syndrome is in children. And so we're going to just have to see.
Got it.
Believe me, you don't want to be the first person to get an mRNA vaccine.
Yeah. So, George, question about screening tests. As a provider, patients are going to be asking, when do you use a screening test in somebody who's not symptomatic? Do you do it always? Do you do it only in people that are on their way to a quarantine situation? Talk a little bit about that.
I think it's almost on demand. And that's what we're working towards. And there's enough virus circulating that it's not unreasonable to have it basically on demand for nasal swabs for PCRs. I think that the antibody testing, every morning my wife wakes up and wants me to get her an antibody test because she's sure she had SARS. And I said, idle curiosity is not an indication for antibody testing. But you can imagine how that goes over. But I think that we're moving to a point where PCR is really basically on demand.
Yeah, it's hard to say no if somebody really wants a test. It's like HIV as well.
And understand that the business of quarantine, if that's not determined by, it's secondarily determined by whether your test is positive or negative. But you have to be a close contact, a really close contact, to warrant going into quarantine. Otherwise, everybody's going to be in quarantine all the time.
So, George, another George in the audience wonders about herd immunity. We hear about this, and people are saying, "Let's just get herd immunity and let it rip." What are the best arguments against that, George?
Well, to start with, that with a certain proportion of people unknown not being immune after they're infected, herd immunity becomes a kind of it's a sort of difficult concept. We'll get herd immunity through vaccination. Herd immunity is the effective reproductive number minus 1 divided by the effective reproductive number. So if the effective reproductive number in this thing running rampant is 4, so 4 minus 1 divided by 4 is 75%. That's what you'd have to get to in order to achieve it. In Sweden, they've gotten to 7.3% in Stockholm, despite letting it all go and despite having a large number of deaths among the elderly.
Because Sweden is, people kind of spin it both ways. They didn't have to shut down their economy, but they got a lot of deaths as a result, I guess. So another question do you expect this is going to be an annual vaccine if we are lucky enough to get a vaccine? Is this the kind of virus that doesn't do lifelong immunity, do you think?
I think the question of lifelong immunity is very open. What I can tell you, though, is that this is a big RNA viruses mutate a lot, but this is a big RNA virus, and it has a gene in it that helps repair, replication errors in its RNA, and so for that reason, we may see some stability year to year. Again, raising lots of IgG to a virus that attacks the respiratory epithelium, you're going to have to get some IgA in there, secretory IgA as well. And I see that as sort of the greater challenge, getting the right kind of antibody.
Yeah, there's actually there's a question from an audience member from Japan on IgA antibodies and whether they might have a role in this.
Oh yeah, big time. Good luck raising them though. You almost need an inhaled vaccine like the live attenuated influenza vaccine to get really good IgA coverage.
That physician also wonders about immunosuppressed people. Might we have situations where HIV with low CD4 or solid organ transplants might be eligible for convalescent plasma as a protective measure?
Well, that's a good idea. There has been some work looking at HIV. People with HIV who've gotten COVID-19, and they don't seem to do any better or worse than anybody else. Now, this is in Europe and the United States against a background of suppressed viral replication and recovering CD4 counts. I know there was at least one case report, Paul, about people with cancer doing worse. I mean, it's probably more a question of do they get the vaccine first,
Right.
rather than giving them, immune plasma, which we don't even know if that works yet or not. The one small trial, but a randomized trial, didn't show an effect.
And I've heard controversy about whether we should be developing basically antibodies to be given as IV for really sick people versus hyperimmune globulin, in a sense, for people like healthcare workers that might be exposed.
Yeah.
Prevention.
Yeah. It'd be great if we could. I mean, it's, a lot of the new therapeutics are based on monoclonal antibodies, and I'm sure those are being pursued as therapeutics as well. If we get a therapeutic that works and it's not that expensive, and anything with the letters MAB at the end of it is going to be really expensive.
Yeah.
You could potentially use it prophylactically. I mean, the places you'd prophylax would be nursing homes, right? Just like in an influenza outbreak, you can go in and give everybody oseltamivir for the rest of the influenza season. I mean, that would probably be the first place I'd prophylax, do pre-exposure rather than post-exposure prophylaxis.
So one person asks about rapid testing and maybe some of the problems that we've heard from the one of the Abbott assays, the rapid test. You want to talk about that just really briefly?
Yeah, the rapid tests never got to antigen testing. Antigen testing has a low sensitivity, like 50% right now. So there's probably not a lot of indication for it, unless I misstated it or it's getting better. The problem with rapid tests is you can only do one test at a time. So while there may be indications for it, like in an ED or, pre-op or something like that, I don't see it as really being a big substitute for, doing more volume testing.
Got it. Another question is about the intersection between HIV and COVID-19, and I can say, I'm the editor of Jade's, that there are a number of papers that are now coming out in a variety of journals that are going to be talking more about that. I think it's fair to say, George, that it doesn't look like there's HIV doesn't seem to protect or make things worse. Yeah. Just it's another infection, but.
That's my reading as well. We're running that series in San Francisco too, so no real evidence yet.
So here's another kind of policy crystal ball thing. We're opening up again, right?
Like the Johnny Carson thing.
Yeah, we're opening up again, and we might see another spike. We probably will.
Yeah. Do
you think the population would sit still for another round of strict sheltering in place? You think, is it just impossible?
I think it would have to be so surgically done, like in one area of one city. And it would take a lot of juice to be able to do that. Those, by the way, are called cordons sanitaires.
Yeah.
In public health, where you basically seal off part of a city, which was done in Monrovia for Ebola. But you'd have to have really rampant infection, and it'd have to be really geographically circumscribed.
That's okay, George.
I've been doing those guidelines all day long too.
I think, George, looks to me as though we're at the top of the hour, where I think we're meant to be wrapping up. Let me ask my IAS-USA colleagues if that's the case. Shall we bring this to an end?
Yes, Dr. Volberding.
That was, yes, that was the plan, Paul, but gosh, we've got so many questions in here. If you both are willing to stay on a bit, we can see that we have a strong attendance still on. You're welcome to continue.
Sure, keep going, Paul. It's fine.
Okay, George, great. So a friend of mine from NYU asks about immunosuppressed people. Are they more likely to acquire this? Are they more likely to have a worse outcome? We talked a little bit about that, but you want to toss it around?
I don't think they're necessarily more likely to acquire it. I think that the kind of standard dictum is they're more likely to progress to clinically recognizable disease and more severe disease.
And there were, again, more questions about we talked about it enough, I think, the possible lull in the fall. talk a little bit more? You mentioned the nasopharyngeal swab as being not exactly pleasant. We've heard that in the news. Are we seeing enough development of oral or just regular throat swabs?
Well, what you're going to see before that is anterior nary swabs. You're just essentially swabbing the nostril. Bonnie Maldonado at Stanford, who I do some of these big studies with, has a paper coming out where they were doing it on babies and didn't wake them up. Just to give you an idea of how benign it can be. So it's but you have to have the right size swabs and all that stuff. If you're the NBA is going to go back and start playing, and they're going to start swabbing people like crazy. These guys are not going to be able to, they're not going to stand for every 2-day nasopharyngeal swabs. Yeah, so they're going to have to move to these things much more quickly.
So here's a question from someone who was watching the news today, where there's speculation that this may, in fact, the virus may have appeared quite a bit earlier than we thought. What do you think about that?
Yep. This is a very cool article. And I can't remember who did it. It was a group.
It was a British study.
Was it a British study?
I think it was an Imperial College study.
I don't think because it was right, so it probably wasn't an Imperial College study. They looked at they had spy satellite views of hospital parking lots in Wuhan, and could look at looked at how full the parking lots were as a function of time. And then also looked at social media, hits for things like diarrhea on the Chinese language internet. And they think it probably went up roughly in November. And the head of the Chinese CDC has said that the wet market in Guangzhou was that was just sort of a kind of one part of this that wasn't the kind of primary event. So it looks like it was circulating a little earlier. I wouldn't give it much, though, before early November.
Okay, great. This has still been a remark. Fast in terms of how much we learned over a period of time, but this has been stunning. And let's just hope that some of the treatments to prevent the really bad outcomes work. I think that's
and I think one of the really interesting things, Paul, is this whole use of preprints, which. Right. Which has burned a couple of journals of note. But I'd never really even experienced those before. Maybe they're more common in basic science, but in epidemiology, they're really not used, and public health they're not used. And it's so, somehow we're having to, peer referee every single thing we read.
Yeah.
In essence,
I think, George, we'll bring this to a close. We've addressed a number of the questions. I was able to sneak in a couple of my own, unbeknownst to the audience. You've been a great assistant with this. It's been spectacular, and I think I have a few slides to show. See if my colleagues can do it. And George, don't leave yet, because I do want to thank you again before we hang it up. But we have IAS-USA is going to be doing more of these, and some of them will address topics that we didn't get so much into today, COVID in women, and updates from the 2020 IAS conference from Monica and her brother Raj Gandhi. Next slide, please. And this is another CME effort that the organization is doing, updates on HIV, including the intersection with COVID-19. We have 3 regional virtual meetings, depending on the time zones. You can do all 3 if you want. They're going to be a little bit different. Next slide. And I think this is my last slide. The other programs that you can go by looking on our website and go to the webinar page. We record webinars, and they've been really well done. I think you'll learn a lot. Obviously, with COVID-19, the things are changing so fast that I'll bet, George, that some of the things we talked about
All wrong. It's all wrong tomorrow.
Even today will be wrong tomorrow. But I think it is important for us to be admitting that, you know, we're having to make guesses at some point about some really important things. But I want to thank the audience. We had a very large group with us today, enough that it knocked my computer off the internet, I guess. And I want to thank my cats for helping me out.
Yeah.
And thanks to the staff as well, George. Thank you very much. And
Always a pleasure.
it's been a great webinar. Thank you.
Take care, guys. Thanks.
Yep.